All right, we're going to review. Start with our review again. What are the core principles of child and adolescent mental health care treatment? First, all children function within multiple systems. Second, care is optimal when systems are organized to coordinate services. Yay.
What a novel idea.
Just talking about
Right. 3, most child mental health issues in children can be treated from a psychosocial approach. And where is psychiatry and medication? Here. I think this particular slide, when we look at the disorders that we are discussing today, the majority of treatment actually does fall here. And so that's an important distinction versus the other disorders that we've discussed thus far. Medication is necessary in some moderate to severe cases or when other psychosocial approaches have failed or are unavailable. And medication should rarely, if ever, be used alone to treat a child or adolescent with mental health need. So let's start with schizophrenia. So today we're going to focus on psychotic disorders as well as bipolar disorders. So we have a lot packed into our time, but also the importance of the medications that are prescribed in these two classes of disorders are really important in that they do have side effects that as nurses that you would be able to really sort of monitor and be very useful in helping providers understand what's happening with kids. So let's talk about the epidemiology of schizophrenia. It's a universal disease found in all countries and at all times with a constant prevalence rates. The incidence is between 15 to 20 per 100,000. Prevalence is around 1%, so that's an important thing to keep in mind. So when you look at these numbers, normal risk, lifetime risk is about 1%. Would you say this is a common disorder or not? No, it's not. So that's an important thing to keep in mind, right? So is that when you hear someone diagnosed with schizophrenia, especially if their diagnosis is pediatric schizophrenia or early onset, is that you should always, in your mind, you should know this is really rare. So and not common like a disorder like ADHD or PTSD, particularly in our population of patients that we're dealing with. Schizophrenia affects men and women equally. It occurs in similar rates in all ethnic groups around the world. And symptoms typically start between the ages of 16 and 30, and most people do not get schizophrenia after age 45. I think that it is also important to understand that men tend to experience symptoms a little earlier than women. And this is not indicated here on this slide, but there is a bimodal sort of prevalence rate. So sometimes women can, it's not common, but women can develop schizophrenia later on in life, where that's rarely seen in men. But there is a thing, even though the common age is between 16 and 30, there is such a thing as early onset schizophrenia or psychosis, but again, it's very rare.
With the women then, if they could get it later, what's the age range
Usually in the 50s.
What?
Yeah.
Stop.
I know.
That's something to worry about.
I know it's just when you think you're out of the woods. Yeah. Yeah, no. Yeah. And I think we'll talk about all of the, the potential. We don't completely understand like the etiology of schizophrenia, right? But, what happens to women after that age, right? So I mean, there's, and we know that there's suspicion that there's a hormonal component to it's complete etiology, but certainly involved in it that we don't completely understand.
That's a research study right there.
Okay, but if you're 60, you don't have to worry about it.
It's already happened.
Nancy, you're fine. Yeah. Don't you worry, Nancy, you're good. Yeah.
60s, you're fine.
Tell that's already happened. Somebody share for me.
There's something for me to worry about.
So there is a schizophrenia it's a spectrum of disorders, and that's something that that we have become more aware of, is that, and these are some of the diagnoses that are associated with this the schizophrenia spectrum. So schizotypal personality disorder. We used to not think of this disorder as a primary psychotic disorder, but we used to think of it more of as a personality type. This would be your person who's like eccentric and quirky and has some magical thinking. We've realized that there are some actual association between this type of personality disorder and a risk for developing full-blown sort of schizophrenia. Schizoaffective disorder is one in which you may have the primary psychotic disorder, and in addition to that, you have mood symptoms that can come and go. So this is where this is differentiated between a bipolar disorder, where you may only have psychotic symptoms in the presence of a manic episode. This is where you could have either weeks of depression and or manic episodes that are in addition to the primary psychosis that occurs despite your mood changes. Schizophreniform is mainly when you haven't reached that 6 month mark of having the symptoms that but all the symptoms to make a diagnosis of schizophrenia are present. Delusional disorder is where that's the only symptom that you have is a delusion which is a fixed false belief. But you have no other symptoms related to psychosis, and sort of on and on. The important thing too to keep in mind is that and you'll see these kinds of diagnoses. It used to be the NOS, not otherwise specified, but other specified schizophrenia spectrum and other psychotic disorders are unspecified schizophrenia. I mean, basically this is saying there are symptoms of psychosis that are present. Maybe it hasn't lasted long enough. Maybe it's not entirely clear. Maybe you're just saying you're hearing voices and you don't have delusions or the other cognitive components of that would make a full-fledged diagnosis. But there are some psychosis present, and we're not sure why. Maybe we're not clear if it's associated with like the substance use or the medication use. And we're still trying to kind of figure it out, but you're saying that you're experiencing these, or we're seeing that you're experiencing some symptoms. And you will see that unspecified diagnosis in psychiatry when there are symptoms present, but it's not entirely clear. And so that when you see that unspecified diagnosis, it sort of helps you to know that the prescriber or the treating provider is noticing symptoms, but it's not clearly meeting criteria for a specific disorder. And so, does anybody have any questions about that? It's just important that you know that that's probably what the thought process is there with it when you see it unspecified. So these are the diagnostic criteria for schizoaffective disorder. Actually, let's start with schizophrenia. So 2 or more of the following are present for a significant period of 1 month. At least one of these must be 1, 2, or 3. And again, this is actually this is incorrect for 6 months. So delusions, again, we are talking about anywhere between, a delusion is a fixed false belief. Usually the important thing to keep in mind about delusions in schizophrenia is that they're bizarre delusions. So, for example, I could have, one could have a belief. I'm trying to stay politically correct. One could have a fixed false belief that isn't necessarily bizarre, right? That in and of itself may not be a delusion per se, but in schizophrenia, the delusions are bizarre delusions that are like really can't happen. For example, a man who would think that it'd be delusional that he's pregnant, right? That's impossible. So that's the kind of bizarre delusions. Other bizarre delusions that are very common. There are common threads that we see is, paranoid delusions, right? That people are being followed, or that someone's after them, that someone wants to hurt them. There are delusions related to religion, so that that they have special abilities or powers or something like that. So these are the kinds of delusions that we see related to schizophrenia. Hallucinations, they can be auditory or visual. And disorganized speech. So this can be one that sort of can be hard to pick up. And I will say that it's very difficult sometimes to try to actually quote someone who is really psychotic, because it just doesn't follow the kind of logic that your mind thinks in. And so to actually try to quote it is hard, because it just doesn't follow logic. But it's a very disorganized way of thinking. And I remember a kid that I saw years ago, and he would say things that he would start off on track, and then he would just sort of fall off and say, and the sun was orange and following. Like, it was just, I can't even make it up, but it was one of those things where you ask, well, what? Like, and you ask the parents, and I asked the parents, does he sometimes say things to you that doesn't make any sense? And they were like, well, yeah, sometimes. He said, well, that's not normal. You should, and sometimes kids say things that don't make any sense, but when you sort of like drill down and ask them, they have a rational reason for why. But it's really something about how the thoughts sort of like derail, and it really doesn't follow the kind of logic. There's either, and sometimes there can be grossly disorganized or catatonic behavior. You can see, and with that, I've only seen this actually only a couple of times, and once was when during a first break, where a young man was, he's really sort of, and he was internally preoccupied, meaning that whatever the voices or whatever he was experiencing, whatever beliefs that he had going on in his head was sort of making him make movements with his body in response to it. And then there's also sort of negative symptoms, right? So these would be a flat affect, isolated, a paucity of speech, which would mean sort of like an inability to come up with the words to say, and those are sort of very common symptoms, and these tend to last for more than 6 months. And there's 1, 2, or 3 must be present, and then these are other symptoms that can be present as well. Of course, with any disorder, there has to be an impaired level of functioning, work, school, interpersonal relationships, that sort of thing. Schizoaffective disorder is differentiated by the fact that there is also a mood component. So the bipolar type is where there's evidence of manic episodes is part of the presentation, or there's a depressive type where there are depressive disorder, a depressive episode that's a part of the psychotic presentation as well. And again, the psychotic symptoms are somewhat separate. You can have psychosis, and then in the midst of your psychosis, you have the 2 weeks for the depressive disorder, the 2 weeks of the depressive symptoms, or with the bipolar disorder, you may have a manic episode. So it's actually having both. So I wondered about cataplexy. Talk a little bit about that. So cataplexy is typically seen, not commonly seen with schizophrenia as much as catatonia. Is that what you mean? Cataplexy is usually.
Catatonia, familiar with the cataplexy?
Yeah. So cataplexy is usually seen with narcolepsy and not with schizophrenia per se. But what did you want to? Yeah, so cataplexy is when someone all of a sudden would kind of lose control of their body, and they would just sort of like seem to pass out, but they would be awake. But that's part and a symptom mainly of narcolepsy, not schizophrenia. And so, but do you all know what catatonia is? Because that's something that is associated with schizophrenia. Okay. Pathophysiology of schizophrenia. And so, you know, dopaminergic dysregulation is sort of at the core of it here. And you can sort of see why when we talk about the medications. Does anyone remember another medication that we talked about that works on dopamine? Increasing it. It was early on. So stimulants. So stimulants increase dopamine. And what we can see is that patients people who use street stimulants, so like amphetamines and meth, that too much dopamine, when we see too much dopamine, what do people look, has anyone ever seen someone that's been on methamphetamines? They are really amped and hyper, sometimes can lose touch with reality. So the idea is that too much dopamine can push you into a psychotic state. And that's what part of the sort of theory around what may be contributing to psychotic disorder. So dopamine is really big. And then there are serotonin is a big one as well. So this is, again, different from the depressive disorders that we talked about, where there's a concern that there's not enough, right? Because when we're treating depression, we're increasing the amount of serotonin that's available, assuming that there's not enough serotonin that's available, versus in this situation where we're saying there may be too much. And let's think about street drugs. Street drugs help us understand things sometimes. So, so we talk about street drugs. Ecstasy, for example, works on serotonin. Remember we said this is one of the things that we tell kids about when they're taking SSRIs. Please don't use ecstasy when you're taking your SSRIs. It could kill you. Well, the idea is that too much serotonin, I don't know if anyone's ever seen anyone on ecstasy, but again, can sort of push you into this state of psychosis, where you're sort of unclear of like what's real and what's not. And then there are some other, we don't know, the truth is that we don't know the exact etiology of why, what causes schizophrenia, although we do have we know that these neurotransmitters are involved, and the medications that we mainly use are focused on decreasing what we consider too much dopamine and serotonin.
I was going to ask about LSD, since it's the one drug that's pretty reliable about creating psychotic
So,
styles of
reality.
reality.
LSD. I'm thinking that LSD works on glutamate. Yeah. So similar to like NMDA.
Yeah, and then the other question had to do with cannabis, because in my immediate caseload in the past, there's been this intense craving. Having said that, at this point, there's types with various degrees of components that I'm not up to date on. But
Neither am I. So what I will say about cannabis is that there are various different types and strains, and and so we can't sort of like put cannabis in and of itself in a.
But part of the management of the case was that the other clinicians were adamant that this not be part of that person's lifestyle, and I was watching just the most canny, manipulative, strategic contacting of dealers done by people who were deep in psychosis and yet still capable of getting their cannabis if they needed it. And there was this, it turned into the case management was all about trying to prevent this, and it never struck me particularly. I didn't know enough to know how is this so particularly bad for them.
Yeah. Well, I mean, so what I can say, and this is what I tell the children who ask me for cannabis cards when I'm treating, is that, you know, the truth is we don't really know exactly all of what cannabis, because it's a large bucket, right, can sort of do. But what we do know, in terms of the association between cannabis use and psychosis, is that for young people who started smoking cannabis earlier on in life, that they tended to have a greater risk of developing schizophrenia earlier. So that's what we do know. And so oftentimes what I will tell kids is that if you have, you are predisposed, if you have a genetic predisposition to have any sort of, because just being predisposed to having, if someone has schizoaffective disorder or psychosis in your family, then you are at risk. And so you specifically don't need to smoke weed because you don't know what's in it, and we have this data point because you're at risk. And so that's oftentimes the sort of message that I give. So if the young person that you're, and sometimes kids I have had kids who have actually, you know, admitted that when they smoke, they become more paranoid. And it really depends on the kind of weed that you're smoking, and I'm not an expert, but there will be a training, and I'm gonna make sure, where's Colleen? So she's not here, but so I will make sure that she's able to get you the information so you can come to that training. It's actually on 420. It's on 420. Yeah. Someone had a sense of humor. Yeah.
I've read some about cannabis. I'm not an expert either, but my son was very, very addicted to it and started smoking pretty early, and then later on did go on to develop schizophrenia. And what I learned is that, you know, there's the two components, the THC and the CBD. And the CBD, they're finding actually, there's studies being done, like in Canada and in England, about how the CBD can actually help schizophrenia. As far as I know, there's no studies happening here around that. And the THC, though, is horrible. And I've watched it in my son, because, you know, we did an experiment. I shouldn't be saying this because he was chasing it so bad.
That's a good thing.
He was, and I tried for a while with just getting the really high level CBD, and it's really different. It was really different watching that than when he went out and got the THC stuff and totally back into psychosis.
Because the CBD has very little psychoactive property to it,
yeah.
and that's why they're using it. There's big conversations going on about its use with seizure disorder. It's
and
being
they
sought
found
for
it effective.
for anti-inflammatory properties.
My dog uses it.
Yeah, pets are using it quite a bit. It's the psychoactive properties that will, you know, enhance anything that's already in there, and a lot of people wind up feeling quite paranoid.
Right. Yeah.
And that's a problem.
Right.
Yeah, because the THC levels are way higher than they were years and years ago.
It's cultivated for that.
Yeah.
I mean, that's what brings the market value high. If you get the CBD, if it's, you know, I mean, that's not all of the. There's two ways that people sell it and market it, and the higher the THC content and the, you know, better its looks and whatnot, the higher value the grower will be able to sell. So that's why.
Yeah, the money, it's all about money.
Yeah, and it's all about money, and our cities are making money off of this. Let's be really clear about this, and our
But what's
state.
upsetting to me is that, there's these potentials for, like with the CBD, and it's not being researched here, and it's not being, you know, but I don't know, so, and it's so expensive to get.
Right. Well, yeah, and I think that's been our sort of issue, is that it's not been well researched, and because it's federally illegal. So I mean, I think there's that part of it. So finding a grant to fund, you know, that sort of thing. But who knows? Maybe that will change over time. You had a question.
I did. Why doesn't the field of psychiatry and behavioral health find a way to measure these levels, these inpatients before you prescribe medication? Because you're doing it blind.
To see like how you would like use your medication therapy to address.
Differently. If you know more where the inadequacies SCHIZ are, or too much of something, then you could really prescribe it more precisely to that particular individual. I mean, how is it okay to do something blindly when you're just talking about some symptoms that really doesn't tell you a whole lot? And I know that's two big questions. I'm
Yeah.
sorry, but
Are you really expected to be? I guess I think that the thing is that we have yet to really come up to have a real consistent way of, or to even know what levels would then make a treatment, right? So like, what does your dopamine level have to be? How do we even calculate what a dopamine level is? Where does the dopamine level come from? Your blood, your brain? We know that the level in your brains is different than what's necessarily in your blood. So I think there's a lot of reasons. If it was easy to do, I'm sure that it would have been, done, right? So I think.
still prescribe these medications blindly, really. I mean, according to symptoms, but we don't understand the etiology of the symptoms.
And so the alternative then is to not treat?
No, treat differently.
But we don't really, I think it is also the case that we don't really understand the mechanisms of all these things. We speculate a lot,
Yeah.
That, like, we speculate that when we give Zoloft, it does X, Y, and Z, but we don't know 100% for sure. So it might be the case, like, you're treating somebody with something, and you go, well, I'm not getting the response I wanted. You might increase that particular dose, but then you might do something that tries to buff up the norepinephrine. So a lot of this we just don't know, and we don't have that snapshot, in the brain maybe we do, and I just don't know.
Well, no, and I think the other thing is that when we think about most chronic medical conditions, right? So let's just think about something really common like hypertension. Okay, so we don't necessarily know. There are some disorders where we know exactly why a person might potentially have hypertension, right? So when we talk about the most common kind of hypertension, essential hypertension, we don't absolutely know why a person has developed hypertension. They have it. And so, but what we look at the symptoms, which are the signs and symptoms, the signs being the blood pressure level itself, the symptoms being if they have like a headache or blurry vision, whatever, and so forth. We also know what the consequences of not treating said disorders are, right? Heart attack, stroke, so forth and so on. And so even though we don't know the etiology of the disorder, we know the potential consequences, and we have some parameters by which we decide to treat. Those parameters, I can tell you, since I've been in medical school, have changed over time, right? It used to be, we all know this, right? Whatever the systolic was and diastolic. So there's no precise science with treating hypertension. It's changed over time, but we know the risk of not treating it is this. And so this is the same sort of concept that we have here with, do we feel like it's okay to treat hypertension? Should we treat it, even though we don't know, like, exactly why someone might potentially have it?
That's a great analogy, because
yes,
we spin this out with depression, with any one of these disorders, what the outcome is.
Right.
I disagree, because what you do know is very different as far as the outcomes. With this, the outcomes are just all over the place for hypertension.
So, can you speak to what some of the outcomes? I mean, I think it's important for us to kind of understand, like, what are some of the outcomes for someone who's dealing with schizophrenia and having symptoms? Like, what are you most concerned about with your son?
Without the medication?
Yeah.
God, so many things. Him, like, getting himself hurt or even killed. I mean, because he's, like, one time he went to the police station to talk to them about intel or something, and I don't, and all the times, or him thinking he could fly, or, any kind of, or just being so, I mean, he's so distracted often and so out of it, like, without his medicine, that I would be afraid he'd walk into the street and get hit by a car. He's just not, he just can't function. He can't function at all. I mean, he couldn't go to school, he couldn't barely do anything. And, yeah, definitely. I mean, and now finally, he's been taking, in Vegas, Estena now.